Good morning. Let's go and get started. It's my pleasure to introduce Dr. Federico Tozzi, who is a new faculty member in surgical oncology, so welcome. Dr. Tozzi is originally from Italy, went to medical school at the University of Siena, and then did his surgical residency at Wright State at Dayton, and just completed his surgical oncology fellowship from City of Hope Cancer Center. And he is going to speak today on education and robotic surgery. Dr. Tozzi.
Thank you. Good morning, everyone. Thank you for the introduction and for the opportunity to be here and to talk to you about surgical education in robotics, a subject that I'm very interested on and enthusiastic. However, it's wise to acknowledge that robotic surgery is controversial since it began 30 years ago and even today. I'm sure that even in this audience there are conflicting feelings. I don't have any financial disclosures. English is not my first language, and forgive my Texan accent. But to start, I'm going to watch with you video to gain your attention and engage you in my presentation. Amazing, right? I'll walk you through the history of robotic surgery, the impact of robotic surgery today, the training tools, the training pathways, the status certification, credentialing with an eye to the future. To start, robot. The word robot is about 100 years old. It was first introduced in the science fiction literature by Capek, a Czech writer, with his play Rossum's Universal Robots. You have a picture here on the bottom in black and white, resembling their characters of display, which are human beings fabricated in factories of organic and synthetic matter. The term robot continued to be protagonist in fiction science literature, and was popularized in the United States with a short history by Robert Henley, science fiction writer, with his protagonist Waldos. The Waldos stories were published in the magazine Astounding. Waldos was a human being born very weak, but very smart, and with the help of his family, he produced a robot, he built a robot, and with a glove, wearing a glove and just moving his hand and his fingers, he was able to manipulate this robot. The fact is, being so weak, he became the strongest human being in the world, and he moved out in space and built his house in the space. So there was a fair amount of amusement around robots, and here in the science fiction, another concept what is introduced, which was telepresence, which means the operating the mechanism, the robot from a different location than from where the robot is. It is also necessary to recognize the contribution to the concept of automatization by Leonardo da Vinci in the Renaissance. He conceptualized the automatization with the mechanic knight. It was this mechanism resembling human beings, and you can see here in the picture, with an internal mechanism thanks to which he was able to open his mouth, moving his jaw, moving his hands and arms. So the two concepts together, the telepresence and the robot, made the telerobotic, which is a much more refined terminology for robotic surgery. But commonly we refer to these technologies as robotic surgery. The approach to the surgical field came in 1983. At that time, we were just at the first phase of the robotic revolution, where industry like General Motors and government agency like NASA were building this prototype like slave arms to manipulate dangerous material. In 1983, in British Columbia, a group of biomedical engineers with Dr. Brian Day, an orthopedic surgeon, used the first robot, the arthro robot, to align the bones after fractures. In 1983, a similar device called Puma was used to do a brain biopsy, to place a needle inside the brain with CT guidance. And so the appreciation of the surgery community was the accuracy of this mechanism and how the robot can be used in this procedure, in surgery. But the approach to, this is a picture of the arthro robot with alignment of the limb, and then the brain biopsy, CT guided, as you can see here, the CT. But the introduction to the surgery of the abdomen came in 1994. Graduate student from the University of Santa Barbara working for NASA recognized that those slave arms could be used in laparoscopy to maneuver, to control the laparoscope, giving a steady view to the surgeon. You can see here how this mechanism was first used in the operating room. A more pronounced intervention by the robot in the operating room came with Zeus. Zeus was built by computer motion and was first experimented in Europe. The innovation in this robot was the presence for the first time of two units. A unit for the surgeon controlling and watching the screen for the optic system, and maneuvering the robot's robotic arm at the bedside. Well, the Zeus hit the news in 2001 with the Operation Lindbergh, a patient undergoing cholecystectomy, completely robotic, in Strasbourg, France, and the surgeon maneuvering the robot in New York. The operation was successful. However, in the meantime, in 1997, the first robotic cholecystectomy was completed in Europe, in Belgium, with Mona, the first prototype of intuitive surgery. So at the end of the 1990s and the beginning of 2000, you have two companies competing for surgical innovation in robotics. These end up with litigation, a lawsuit. In 2003, the two companies merged in intuitive surgery to put together the effort to develop this technology. Zeus, which was described in the literature in many reports for cholecystectomy, Nissen fund application, hysterectomy, then was phased out for the Da Vinci system, which is the current and only system available, with two generations, the SI, the first one, and the XI, the second. We'll go through the details of the technical details of this system in a few minutes. But what are we expecting in the future? There are several players willing and planning to put new robots in the market and take off the monopoly from intuitive surgical. Verb Surgical, which is a joint venture between Google and Johnson & Johnson with their division with Ethicon, claim to have a better optic system, an analytic system of data interoperate to optimize the use of the robot. But what most important is the return of haptic feedback, meaning the tactile feedback that is lost in robotics will be back with, they claim, with Verb Surgical. The same haptic feedback is claimed by Transenteric Gears, which is a company based in North Carolina, which was just approved by the FDA 10 days ago with their robot, which will look in a market different than the Da Vinci system, with a much more affordable price. But I'll pause here. What's happening in these last 30 years in surgery? A true revolution is happening. In the 1980s, laparoscopy was introduced, with the first laparoscopic appendectomy and the first laparoscopic cholecystectomy in Germany by Dr. Sim and Dr. Muhe. Ever since, laparoscopy has been a protagonist in the minimum invasive surgery throughout the world and the United States. I think it's correct to say that in these 30 years, robotic-assisted surgery developed in parallel to laparoscopy with the purpose of overcoming some of the technical limitations of laparoscopic surgery. I couldn't complete to talk about the history of robotic without giving a picture of my hometown, Siena, which is a medieval city with, of course, a lot of history. What is the impact of robotic surgery? So how to gauge this information, I show you here on the right side the number of publications throughout the years in robotic surgery in peer-reviewed journals. But more in the specific on the left side, of the report of the ACRI, which is an organization that monitors the introduction and the utilization of medical advice in patient care, shows a rise in a period of 4 years of the number of surgery completed with a robotic system. This rise, though, if you look at the graphic in detail, is mainly due to the increased number of general surgery procedure. This data is also confirmed by the annual report of Intuitive Surgical, where they claim that general surgery is the fastest growing subspecialty in the US, with 186,000 procedures in 2016 versus 109,000 procedures in 2015. The application of the robotic, the Da Vinci system is throughout all the surgical subspecialties. Some subspecialties develop their own robot, like the CyberKnife in neurosurgery, and orthopedics have their own robot for hip replacement and knee replacement. However, it's correct to say that even if the application of the robotic surgery is so broad, in the world of minimum invasive surgery, laparoscopy still has the lead. And so it's necessary to compare briefly the difference between laparoscopic surgery and robotic surgery. Simply, the the standard laparoscopy has rigid instruments with 5 degrees of freedom. This limitation resolved in the robot with the Endoruis, which is patented by the Da Vinci system, with 7 degrees of freedom. However, with the Endoruis, you have complete lack of haptic sensation, the tactile feedback, and somewhat is reduced, actually is greatly reduced in laparoscopy, but with the robot is completely eliminated. The incision side, the minimum port side is 5 millimeters for the laparoscopy and 8 millimeters for robotic surgery. The optic system from a TDU where you lost the depth of the field goes to a 3D system with an excellent 3D dimension and depth of the field. In addition, in the last generation robots, you can go up to magnification at 10%, increasing your accuracy. You have loss of natural hand coordination laparoscopy, and this is given back by the in robotic surgery. In addition, you have complete tremor filtering and motion scaling. In laparoscopy, you are at the bedside, which actually, in terms of training, it's better for the resident, the fellow, since you maintain a relation with the surgeon side by side. In robotic, there is a physical separation, the surgeon at the console and the surgery that takes place at the bedside. Therefore, there's a separation which becomes difficult to train a new surgeon. They claim a better ergonomic versus the laparoscopy, which is recognized for distress at the joint of the hands, the elbows, the shoulders, and the neck. However, those are not well documented in literature because it is primarily subjective. But what is the outcome? So how can we compare laparoscopy to robotic surgery? And of course, I have to include open surgery. So I review a series of meta-analyses, and the results are heterogeneous. However, on the first line, just to give you an example, gastrectomy for cancer, in a meta-analysis that includes 2,000 patients, you have about 404 patients robotic, 700 patients laparoscopy, and the rest are open. What they claim in robotic is less blood loss, short length of stay, adequate lymphadenectomy, higher OR time though, and higher cost. The higher cost comes across all the different procedures. And also, in most of them, the time in the operating room, except for the gastric bypass. For one of the most common procedure for the general surgeon, in this study here at the bottom, for cholecystectomy, they did a case match analysis. This is a retrospective study in a single institution comparing 100 robotic case and 100 robotic and 100 in laparoscopy. They report higher cost and a higher rate of reoperation. For this study, the single-site robotic system was used. So not a true advantage. But when you look at distal pancreatectomy, for instance, at the cost of a longer operative time, you had decreased length of stay, decreased blood loss, and the same R0 resection with a high rate of spleen preservation. So there are some advantages, but the results are heterogeneous. And I invite you to consider robotic surgery in selected approach. It's also important to understand what is the perception of the patient. One day you're going to be, for the trainees and the students, one day you're going to be a surgeon making decision with your patient to take this technology to the operating room. This study shows the result of a survey counting 101 patients and 58 healthcare providers. So what they did, they asked questions about laparoscopy, how different it is from robotics, looking in the specific at the rate at the incision, the infection rate, and the operating time, and other variables. And what it shows is, if you just look at the top, they claim that the infection rate is smaller when actually is greater. They blame that with robotic, the incision is smaller, which actually is greater. So this just to compare to the clinical evidence. This just to suggest that there is a discrepancy between the perception of robotic surgery from the clinical evidence among patients and healthcare providers. This brings another question into place. What is the advantage of having a robotic system for a hospital, for an institution? Well, it becomes necessary to underline what the effect in the market to have a robot in the institution. So in this study published in surgical endoscopy, what they showed is taking the patients taking cases from the national inpatient sample linked to the hospital market structure. They're able to map the 5 most common procedures done robotically: prostatectomy, partial and total nephrectomy, hysterectomy, and oophorectomy. And then they divided the hospital with the Herfindahl-Hirschman index, which is a metric to understand and to represent how the hospital is competitive in that specific region. Then they divided hospital in competitive and moderately competitive. Now, if you look at the relative risk to undergo the procedure robotically, the competitive always is skewed towards the left side, suggesting that the patient undergoing surgery in a hospital in a competitive regional market were more likely to undergo a robotic assisted procedure. There are, though, advantages in a robotic surgery that I have to recognize. At City of Hope, with our chairman, Dr. Fong, the innovation in robotic surgery is pushed to the limit. And I want to show you here a short video of a procedure done at City of Hope that I presented to the SSO conference last year. The position of this lesion, which is a cholangiocarcinoma, is posterior in segment 7 of the liver. Very difficult to reach with a laparoscope. With a patient in a lateral position, and the right triangle ligament hanging the right lobe of the liver high and give the opportunity to gravity to open up the plane of dissection or resection, which is underlined with the scoring the capsule. Once the capsule is open with the robotic instrument, the vessel sealer, the parenchyma is divided. And to confirm the position of the mass with the resection plane, we use an ultrasound. And here we have the ability to look at the mass as we maneuver the ultrasound probe with the robot, which is extremely advantageous. Free margin at the end of the procedure, and the specimen is removed from the abdominal cavity. The patient left the hospital 3 days after the procedure. When it comes to training, finally, I see 4 blocks: simulators, mentorship, dual console, and robotic courses. The general goal for a robotic curriculum is to learn and teach the correct application of the system, understand the safety measures, and make the surgeon to be a competent and proficient robotic surgeon. How do we accomplish that? Well, starting from the simulation, which was first introduced with laparoscopic surgery. In the market, we have 5 different simulators. The most common is probably the Da Vinci simulator, the DVSS, and each one of them, except the Promise one, which is this one here, have the ability of the end-or-wrist manipulation, which is patented by the Intuitive Surgical. And if you can see, most likely that drives the price of the simulators. In fact, the Promise, which does not have an end-or-wrist, is $35,000 versus the rest of them. So you have to consider, if you're building an educational curriculum in robotic surgery, it is an important investment for the institution and the hospital. The Da Vinci system is not considered cost-effective in this review article. Why? Because even if it's $90,000, you had to have a console available to use the Da Vinci simulator. This problem resolved with simulators that are more expensive, like the Mimic, the MDVT, and the ROS. All of them have camera clutching, the ability with needle control and needle driving and system setting. And all these simulators are reported mostly without comparing one another in the literature. However, there's no standardized parameters to help the educator to decide which simulator is more convenient for their program. The core of the curriculum comes with the mentorship, which is divided in 3 parts: the live cases observation, the bedside assistance, and the surgeon console. The approach is progressive, stepwise, as it shows on the right side of the picture. For the live case, the resident, the trainee, the fellow, first is observing the case to familiarize with the robotics communication that takes place in the room, the robotic space, and familiarize with the procedure. To move forward with the bedside assistance, where you have a full understanding of the robotic arms, the docking, undocking during emergency situation, and familiarizing with the robotic boots and instruments. The critical component is going to be the surgeon at the console, which is supervised by the attending surgeon, and where the trainees takes a role in positioning the patient, decide the port placement, depending on the complexity of the case, and when a stepwise approach should be used to progress through the procedure. The question is this stepwise approach can be generalized to all the procedures, or have to be procedure specific? We don't have an answer today. And of course, team training and communication is key in robotic surgery. Again, why? Because you're not at the site of the patient with your trainees, but you're detached at the console. But this deficiency has been addressed, as I'll show you. So the stepwise approach is described in the literature, and in this article in particular, with a very simple exercise. This is done with a single surgeon and a single fellow. Of course, it's a limitation, but this is an example. For a gastric bypass, and the gastro-J as the task to complete, it was divided in 3 parts: the anterior layer, the posterior layer, and the closer of the enterotomy. Then the surgeon and the trainee complete 30 consecutive cases, 1 to 10, 11 to 20, and 21 to 30. The fellow in the first 10 cases will do all the task A, and then in the second, 11 to 20, introduced to the step B, and therefore in the third part, A, B, C. So was a progressive introduction to the engagement in stepwise in the procedure. Turned out that the operative time, the doc time, was the same throughout the 3 blocks, 1 to 10, 11 to 20, and 21 to 30. There was no change in the operative time, no statistical significant difference, and no adverse robotic events or surgical complication. This is an example of the stepwise approach. Of course, you had to think about 30 cases, and if you have 30 cases, to train each resident in each specific procedure. The detachment from the resident or from the trainees to the surgeon is resolved with the dual console that Intuitive Surgical has available at a very pricey cost. However, the amazing component of this tool, which is 2 separate consoles side by side, allows you to operate simultaneous, taking back what originally is the training, the surgeon and the trainees. You can move both instruments, all 3 instruments in the swap mode simultaneously, or the other modality is the nudge mode, where only one surgeon can do the procedure and the other one is in autopilot in autopilot, like an airplane. The advantages of the console are here exemplified in this training exercise. Here, the task in a dry lab was to divide a penrose with robotic scissors, and the time, how long it takes for the resident, and then how long it takes with the resident with the swap mode in collaboration with the attending. And they notice a 34% reduction in time in swap mode. The reduction time comes 25% when they invert the role, meaning the operator is the attending surgeon and the assistant is the resident. In other words, what are the advantages of the console? Engaging hands-on of both surgeon, which is very different than what we had without the console. Allow to stop the trainees in emergent situation, another key advantage that takes a lot of anxiety off the attending. And remote proctoring. So in this case, the remote proctoring, you can use virtual arrows to guide the trainees to complete the procedure and find the anatomic space that they want to dissect, for example. The disadvantages: high cost of the console is about $500,000 to add on top of the cost of the robot. Additional assistant: if you have your resident at the console with you, you need another assistant at the bedside. And the room capability. These tools are very voluminous, so the room sometimes can be a limitation. When it comes to training courses, now Da Vinci the intuitive surgical allows and promotes the use of the robots with their own training pathway, which is divided simply in 4 goals and a progressive introduction to the technology, to the mechanism of the robot, including the clutching, the 3D dimension, to then in phase 3 introduce the surgeon at the console in the real in live operation with a peer-to-peer and proctoring experience, which is specialty specific. And then you can move forward in phase 4, to continue your training and development, and continue education in technique and new technology. However, here another limitation. There's no report data on the effectiveness of the curriculum. Another approach is the fundamental of robotic surgery. This is a curriculum more complex compared to the previous one and more complete, which was put together by a consensus of robotic surgery experts representing 14 international surgical societies. The training curriculum that resembled the intuitive surgical curriculum, with addition and actually the promise that those tasks will be validated. However, 5 years later, now at today, or 6 years later, still we don't have a validation of this curriculum. But how we reach credentialing to use the robot as surgeons or new attendings? So looking at the organism of regulation, the FDA approved the Da Vinci robot in the year 2000, but they don't mention anything about what the pathway for credentialing surgeon. They just want to guarantee the safety of the platform for the patient and the use by the hospitals and the surgeon. Moving forward, in 1984, this was at the time of the Zeus. There's a consensus statement by the American College of Surgeons where invite the surgeon to use new technology judiciously, but yet does not give specific guidelines on how to train and credential a surgeon in robotic surgery. There is a document very much complete, which was published in the Journal of Surgical Endoscopy by Heron, of a multidisciplinary consensus at SAGES, where they go through the principle of training in robotics, such as training and credentialing, clinical application of robotics in surgery, the risk of surgery, and cost-benefit analysis as well as research. However, what we miss is the volume. We miss the numbers of the surgeon or the trainees that need to accomplish to be proficient and capable. But where are we standing in terms of, as a resident, counting your numbers towards graduation? The ACG case log system for general surgeon does not include the option to log in robotic cases, which I think is a substantial limitation. The ACG case log is based on the CPT code, which does not include robotic surgery. The situation is slightly different for the gynecology residency program that started in August 2017. When they log their cases, they have the possibility to check the box robotic. But the Association of American Gynecologists does not shows what indeed are the training and the landmarks to train their surgeons. A similar situation for urology residency, and I must say urologists are the first group that embraced this technology more than anybody else, where since 2013, laparoscopy can also be changed to to log in cases into laparoscopic robotic surgery. So the ACGME should consider to align case log system for robotic cases. The credentialing system. Credentialing is different from every institution. Here's an example. In this study, based on a survey in the state of Alabama, they asked 16, 17 hospitals what is the credentialing system. And just to show you, 9 hospitals request an attestation letter, 3 hospitals they list robotic cases, 2 hospital proctor cases following residency, 5 require certain numbers of hysterectomy. Median 5 range to 10 and to 2 at 10. Now the sample was very small, therefore no significant, but just to give you the message that currently there is no standard credentialing requirement for robotic surgery. Credentialing is institution dependent. So the question is, should we hate the robot or love the robot? Why do I ask this question? Because during training, I must say that I recognize the robot to be residence and friendly. You will be sat at the bedside and use the suction here and there, change the instrument, but not really engage in surgery like in open surgery. Much more fun, right? So I decided to ask this question to my surgery oncology fellows. And I noticed that at the end of their training, this is just recent graduates from surgical oncology fellowship, the use of robot does not make any difference in terms of where their practice is, academic and non-academic, but there is a difference between in their practice if they use a robot more towards HPB, hepatobiliary surgery, and colorectal surgery, where robotic surgery is becoming to be more frequently used. Well, what is their opinion? Well, 87% are in favor for the use of the robot and to be trained during fellowship. However, integrated robotic training in fellowship, only 36%. And at the end of the fellowship, only 21% receive a certificate, which we don't know exactly the details of the certificate since it's not standardized. So what are the final considerations? Well, there's no national standardized curriculum. Therefore, the institution, the school, kind of have the moral and ethical obligation to have a institution training program robotic surgery. There's no current validation of robotic training. This can be resolved in the future with a global effort to collect data. And I'll tell you more in a second about this. And there's no uniform credentialing. So I think it's necessary to promote a standardized credentialing for the safety of the patient, the safety of the surgeon, and the practice of the surgeon as well as the hospital. The goals, again, safety, optimal patient outcome, and shorter learning curve. What are the possible directions? This is just my personal opinion on how a vision of what can happen in the future. I think the introduction of the robotic technology and this computerized system gives you the opportunity to collect data. Advanced data collection might be the answer. From the simulator, the novice surgeon, the trainee seat of the simulator complete a series of skills and with a score of their capacity. They measure the tissue handling, the dexterity of the surgeon or the trainees. Then in the operating room, data collection from docking time, total OR time, but more in the specific, the collision intra and extracorporeal, the inertia of the surgeon operator with the maneuvering the instruments, the distress of the tissue, and the range of instrument motion. And finally, the patient outcome from the perioperative outcome, like estimated blood loss, length of stay, introduction of the diet, the quality of oncologic resection. So if we find a system to collect all this data, they will be obligated and challenged by creating an algorithm that, for instance, an example will give a feedback to the surgeon that will suggest that there's too much inertia in the motion, that wastes too much time. The tissue handle is not optimal. And this will allow to shorten the learning curve and take the best opportunity in every single procedure to advance in our capability and proficiency. I hope my patient will not react to this when I talk to him or her about robotic surgery. Thank you for your time, and open to questions.
Questions for Dr. Tozzi?
Thank you.
So, I think it was a really great talk. I enjoyed it. You did a very nice job. You know, here's a question. So, you know, the argument I guess would be, what's the real benefit? And you know, you point out that meta-analysis a little bit. And meta-analysis based, I'm sure, all observational studies. And the two advantages seem to be lower blood loss, right, and shorter length of hospital stay. So lower blood loss, you could argue, might be due to the fact that if a patient, if a student through robotic surgery and he experiences a lot of blood loss, he's just going to open the patient up. That's going to be counting as an procedure. So basically, you know, the blood loss is going to trigger going from robotic to open, and the patient would then be counted as having an open procedure. The short length of hospital stay could just be attributed to the fact that you can pick out healthier cohorts of patients for robotic surgery because the length of operation is longer. So you're not going to take somebody with a lot of comorbidities and subject them to a robotic. You can subject them to an open procedure, and therefore you would expect hospital stay to be shorter. So I guess with that in mind, I mean, you know, at the end of the day, I mean, what is the real advantage?
I appreciate the question, and it is true. I think the answer is to be very specific and selective of the patient you're offering and therefore performing robotic surgery. For instance, it would be interesting to see what is the correlation between the use of robotics versus laparoscopy and open surgery in consideration of frailty index that represents a measure of how the patient is strong, how the patient can overcome the surgery and the recovery. Again, I think the main advantage is is technical. I give an example. For the ENT surgeons, they use the robots for transoral procedures. In this case, they have to operate in very narrow cavities with bone prominence. Therefore, the space is very limited, and the chance to use a robot give them accuracy that they cannot achieve with in open surgery. As I showed you in the representative videos, lesions in the posterior aspect of the liver, those can be reached with the laparoscope, and I think it's pretty more common than robotics across the nation, as I learned when I presented this SSO. But it also depends on your laparoscopic skills and experience. What the claim for robotic surgery is a shortened learning curve. Now the question is, what is the learning curve? Well, the reports in the literature are procedure specific, and the range it's all over the place. From, for instance, 20 to 40 procedures for a gastrectomy, versus compared to laparoscopy in some studies that goes up to 60 to 80, 100 procedures. So they claim that the learning curve in robotic surgery is shorter, but indeed needs to be demonstrated.
That's a good talk. It's a great review. Really appreciate the historical perspective. I'm a biased end user. I firmly believe in robotics. I think it makes you better. That's the bottom line. When you're operating technically, it just makes whatever you can do a little bit better because you can see it, and the fidelity is incredible. But the problem with robots is access, right? You came from City of Hope?
Yeah.
How many robotic?
There are more robots than operating
in the
rooms.
hospital?
There are more robots than operating rooms.
More robots than operating rooms. All right. Well, unfortunately, we don't have that problem here. We have 40 operating rooms, and we have one robot. And so I've always believed to train in robotics, you need more robots. The only way to get more robots is to do more robots.
That is very
true.
true.
Do more robots.
That's practice is what makes you a surgeon. But it's also true that one of the messages that I have for you is you have to optimize these opportunities. That's why I think the training curriculum is important. and forget about the fact that we don't have a validation. But I think we are in a stage where we had to anticipate the validation, which I think is very technical, difficult, and therefore have very own in-local validation of your curriculum, like you guys are doing. And one of the comments that I just received from Dr. Weincycle, I mean, he's an advocate of robotic surgery because I think he says makes him better. And I think the word goes through the to the early residents in training and also the medical student. I want to share with you what was my amusement when I first was introduced to the robot. And I invite you to find a way to document this and to prove. But as a medical student that approached surgery or the early resident, the vision of the robot, the 3D dimension, gives you a complete, unbelievable understanding of the anatomy that is very far from book and very different from open surgery and laparoscopic surgery. I think gives you the chance to understand anatomy at a higher level than from other surgical experience or your studying.
Thank you for this talk. I thought it was interesting. I don't do robots, but in this era of financial responsibility and limited finances for most hospitals, and the move towards value-based care, where costs are being looked at in relation to patient outcomes, and very weak data suggesting that robots are better. But despite it being around since 2003, study. How do insurance companies and CMS look towards robotics in terms of reimbursement and approvals for these cases?
To be honest, I don't know the specific reimbursement. They do reimburse as laparoscopic cases. So the hospital takes the additional cost of the robot. That's my understanding. Yes?
And along those lines, so Ken, sort of both of these, it seems like we're sort of bad-mouthing the hospital for not getting us another robot. But from the hospital side, until they see a benefit for their cost, they're probably not going to pony up. So why aren't we asking the school to buy us a new robot? And because, like you said, right now it's mostly for training, developing proficiency. It's our side of things that are benefiting from it. And once the hospital sees the benefits of it, then they can buy a third one, and fourth one, and fifth one. But right now, I don't think the robotic surgeons have shown the hospital a benefit to them yet from the robotic.
Yeah, that's true. And Ronnie, we've talked about the prospect of the School of Medicine helping out to pitch in because we are the ones technically using it. The logistics is the problem. You're asking a School of Medicine to purchase a capital item and house it in a building that we essentially have no control over, that then they assume the maintenance and cost it. So it's complicated. To me, the interesting slide was the competitive, non-competitive hospitals. So to me, that says, which is actually true, is that University Hospital technically is not competitive, it's a non-competitive